All right, so cardiology is going to go ahead and be the kind of a huge area for us in EMS. And by a huge area, I mean that it's an area where we run a good majority of our calls at. You can pick just about any, especially in the South, you can pick any locale, any 911 market, and the majority of your calls, about 45 to 50%, depending on the area, are going to be cardiology in nature, cardiological in nature. You might think to yourself, why is that? Well, damn Bojangles is why. Have you had the spicy chicken sandwich from damn Popeyes? Apparently it's worth dying for because it's clogging arteries left and right, but it sure is good. So we've got sedentary lifestyles where people are not very active. Then you got poor diets contributing to a buildup of lipids, which is called atherosclerosis on the arteries and veins. And then you have hardening of the arteries, and that's called arteriosclerosis. Do not get the two confused. Artery, art hardens. Remember, paint hardens. Arteriosclerosis is hardening of the arteries. And atherosclerosis is going to be a plaque and lipid buildup from Bojangles. And together they make up coronary artery disease. So around the world, worldwide, about every year, 17 million people die of cardiac disease. 17 million. That's a lot of folks. And then in the US alone, over 850,000 people per year die of cardiac disease. I think the last numbers I looked at, there was like 1 every 30 seconds. Somebody's dying of cardiac disease. It's the #1 killer of Americans. Why do you think that is? Well, again, Bojangles. It could also be processed foods. It could also be, again, sedentary lifestyles where people aren't getting up and actively moving their bodies and muscles. Your body was meant to move and work, not to sit around and do nothing like a lot of ours do. So huge number of your call volume is going to be cardiological in nature. And if you really, really get down to brass tacks, a huge number of what we do is keeping the heart and the brain and the lungs alive and moving. Everything else can be pretty goofed up, but as long as the heart and the brain and the lungs are perfused, and we're doing okay. So cardiology is going to be the study of the heart. A cardiologist will be a physician who specializes in studying the heart. And you, the paramedic, EMT B or EMT A, may sometimes be the only cardiologist that someone will see for quite a while, depending on where you work. When I worked in South Georgia, the closest cath lab to me was about 45 minutes. That's because Phoebe Putney was 45 minutes south. The Macon Med Center was 1 hour and 30 minutes north. If I wanted to get my patients somewhere quick, it wasn't going to happen quick unless I flew them. There's a lot of different aspects to EMS that change from the metropolitan area to the urban rural area. The challenge we have together is to make you understand that, yes, you are trained by Georgia paramedics and you will work in Georgia, most likely, but also the fact that you're going to take a national standard education exam. You're going to take a national registry test. And this national registry test is going to be covering a slew of aspects that you probably haven't even thought of, such as like Jethro's ran his car into a cow that was in the middle of the road, so he T-boned it. Dad joke. Whatever, I'm funny. So also we have, like, I had a student last year in my paramedic class from Alaska. He worked as an EMT in Alaska before he came to Atlanta Fire to work as a firefighter. He finished his paramedic first try, fantastic student, but he told me things that I did not even consider about EMS because, I don't have to worry about polar bears crashing my scene. Apparently the bastards do that quite often up there. So like they had to wear like a gun necklace at all times just in case they had to pop one on them. So that's not something I think you're going to have to worry about here in the Atlanta area, unless there's something. Go to the World of Coke or the zoo maybe, and one of them might get you there, but pretty rare occurrence at this point. So the heart is comprised of how many chambers? Let's talk about it. Move all the stuff out of the way. Oh yeah. So I'm gonna draw just a kind of a lovey-dovey heart here, not the real anatomical one. We got 4 chambers in the heart. The upper chambers are called the atria. And the bottom chambers are called the ventricles. We'll call them vents for short, because I ain't got time to write all that. So the atria are much smaller. They are responsible for receiving blood outside of the heart. The ventricles are responsible for pumping blood out of the heart. Now, blood comes into the heart by three different aspects. Three different types of pipes bring it in. We have the superior vena cava. Superior means it's above you. So all the blood that drains from the face, the biceps, the ears, the brain, all that is drained into the superior vena cava. Now let's do a process of elimination. The inferior vena cava drains what? You guessed it. Yep, the lower half of the body. All the lower half of the body is drained by the inferior vena cava. And there's one more. Who have we left out? We've left out the heart muscle itself. Because remember, cells make up tissue. Tissue makes up organs. Organs make up organ systems. And the heart is made up of cardiac myocytes. And those cardiac myocytes have to be fed, full-time fed, by blood flow. And when they're done feeding the heart has to drain somewhere. So draining the main vein, this is called the coronary sinus. This is called the coronary sinus. So sinus is a way to drain. So sinuses, they drain. So again, superior vena cava, inferior vena cava is who we have. Let me let this in the room. There you go. So superior vena cava, inferior vena cava, and the coronary sinus. Now blood then will pump into the right atrium. Right atrium is where all the blood returns. When we talk about terms like preload, preload is the amount of blood left in the ventricles after it has pumped blood out. But preload also kind of preludes to left ventricular end diastolic volume, or the amount of blood that's coming back to the right side of the heart. It's one thing to pump it out, but it has to return. It has to circulate. For you to live, you must have what? An intact pump, intact circulatory system, so intact pipes, and enough fluid in the veins and arteries to reach the metabolic goals of your body. So the coronary sinus, superior vena cava, inferior vena cava feed blood into the right atrium, and then we got valves. Now valves are meant to be one-way structures where blood flows one way through it and then does not flow back. So we have four valves: the tricuspid, pulmonic, mitral, and aortic. So toilet paper, my anus. Tricuspid, pulmonic, mitral, aortic. Toilet paper, my anus. So the first guy over here is going to be the tricuspid valve. Blood flows through him to the right ventricle. Remember, ventricles are bigger. They got a little bit more muscle to them. So their job is to pump blood out of the heart, to get it out. So the right ventricle pumps blood through the pulmonic valve. There's your P, toilet paper. And that pulmonic valve, where do you think it goes? Pulmonic, pulmonary, to the lungs. It'll pump that blood to the lungs where it is oxygenated through the process of diffusion, where the gases travel from an area of higher concentration to lower concentration, and then they travel through that single cell endothelial wall of the capillaries, and then we have an exchange take place. Your body must take in fresh oxygen, and it must get rid of carbon dioxide. Carbon dioxide will be a byproduct of cellular respiration. So as we have this oxygen come into the body, it's transported to cells. And again, cells make tissues, tissues make organs. Those cells must have oxygen, water, and glucose to create adenosine triphosphate, which is energy. If it does not have oxygen, it will try and perform that oxidative process inside the cell, glycolysis, without oxygen. Oxygen is the oxidizer, and it will not produce energy, it will produce acid. But in a healthy adult and healthy cells, it'll produce adenosine triphosphate, ATP, with energy, and then it has a byproduct. When you crank your car up, it spits out exhaust gases, carbon monoxide. When your cells go through their little process of breaking down the oxygen and the sugar, what happens is that it spits out a byproduct, kind of an exhaust gas. It's carbon dioxide. Now, carbon dioxide is toxic to your body. It's acidic. You must get rid of it. In your brain, you breathe off of a carbon dioxide drive in your cerebral spinal fluid of your head here. Your chemoreceptors around the medulla oblongata and the pons, they'll sense changes in carbon dioxide. So whenever your carbon dioxide levels rise, your body's like, oh, that's too much, breathe. That's too much, breathe. And based on those chemical receptions that it's taking and those micro measurements, it knows how fast you need to breathe per minute and how deeply you need to breathe. A good example I can give is that I was dispatched a couple times, but one time I remember was to a kid who was throwing a fit with his mommy. It's in Buckhead District, so he was a spoiled brat. I'm going to hold my breath until I get my way. So he held his breath and passed out. I watched it happen. I wasn't about to stop him. It was quite enjoyable to me. So he passes out, and what happens is that he breathes, he's passed out, his body regulates because it's smarter than he is and smarter than we are. So he breathes really fast for probably about 30 seconds to a minute. His body regulates the pH, or his acid-base status, and it goes back to a normal stance. And then he woke up eventually, and he didn't want to do it again because he had a hell of a headache. You know, sometimes you just got to let God sort him out. That was Control-Alt-Delete for him. So we've got blood going through the pulmonic valve to, again, the lungs, and then that process of diffusion, we have gas exchange. You breathe out CO2, you suck in oxygen. About 20.84% of the ambient air around you is oxygen. Everybody just rounds up to 21%. So we got oxygen coming in, carbon dioxide has to be breathed out. When you breathe out, you're breathing out heat, carbon dioxide, and water droplets. The average adult loses about 1,800 cc's of fluid per day by just breathing out. So that's we are losing fluid that way. Now think about the asthmatic patient who's having a respiratory distress. You can do a lot of good for that patient once you fix their breathing, get them a little IV fluids going, because they are probably working their way towards dehydration. They blew off a lot of liquid out of themselves. So that blood is now oxygenated. We'll come back to the left side of the heart through 4 very special veins. These pulmonary veins are the only veins in the body that carry oxygenated blood. Because remember, veins normally carry unoxygenated blood, and arteries carry the oxygenated blood. So it comes over here to the left atrium. And then the blood will flow through the mitral valve. Some people call it the bicuspid because it has 2 little cusps, but it doesn't matter. Depends on who you're talking to. So mitral or bicuspid valve. Then we have the big boy. The left ventricle is the biggest, hungriest part of the heart. It's the biggest, hungriest part of the heart. It's going to be the one responsible for pumping blood to the rest of the circulation throughout the body systemically. This is the big boy. So the heart then will have blood spit out the aortic valve, and then the blood will flow to the aorta. It goes ascending aorta, aortic arch, then descending aorta. And one of the first places that blood goes after it exits the heart in the aorta is the coronary arteries. The coronary arteries are responsible for feeding the heart muscle itself. What would happen if I tied a string around my finger here? It would turn red, blue, purple, black, and die. The tissue would be starved for oxygen and blood flow. And when we talk about running cardiac calls, a lot of times the problem is that there is a blockage of blood flow to that cardiac muscle. And it's going to cause the heart muscle to turn red, in theory, red, blue, purple, black, and die. The tissue will die. There's 3 phases and 3 spots. Well, 3 phases we could talk about this happening in. So phase 1, we're talking about ischemia. Ischemia really is just a lack of oxygen. A lack of oxygen. It's just got a low oxygen content. And you might even get ischemia just walking up some stairs, you know. I know I will, because ischemia is created by a supply and demand issue. So ischemia is the first stage that we enter in. There's just not enough oxygen. And again, most of us throughout the day will throw a PVC here or there or be slightly ischemic, but your heart doesn't like it. Whenever it gets ischemic, it gets irritated, and you might have a palpitation. You might throw a PVC, which is a premature ventricular complex, where there's irritated ectopic foci, where there's a piece of meat over here that's ischemic, hypoxic, and he's pissed off. So he has enhanced automaticity, or he creates electricity, and he'll take over the heartbeat for a second. And it's just a common thing that does happen to me and you throughout the day. Ischemia for 1 to 2 minutes can cause this. The next phase would be injury. What does it mean to be injured? Well, it means something's hurt. That means that there's now damage being done. Damage is being done. And then the third phase we call infarct or an infarction. So when we talk about a myocardial infarction, an MI, we're talking about the fancy way for saying heart attack. The heart is not actually attacking you, it's just dying because it has a supply and demand issue. It's demanding more oxygen than your body can supply. Either it be a metabolic issue from lack of blood flow due to clotting, thrombosis, embolisms, or it could be an issue that you don't have enough oxygen content in your system due to something, let's say, like anemia. Or if you like fail a test and I stab you in the kidney and you bleed out, you won't have enough blood in your body to actually meet the heart's demand. So either way, same thing. Modern problems require modern solutions. Jot that down. So 3 phases: ischemia, low oxygen content, injury, damage to the muscle. Infarction means dead. The muscle is dead. So let me go ahead and tell you that dead meat does not beat. When there's tissue in the heart that has been infarcted, it is now dead. It does not have any characteristics of the normal cardiac muscle. So while I'm talking about it, what are the normal characteristics of cardiac muscle? I've already mentioned one, but I'll go ahead and say it again. The first one will be automaticity. Let's break that term down. Auto, meaning self or by itself. M-A-T, maticity will mean electricity. So the heart has the ability of automaticity, which means it can create its own electricity through what we call the sodium-potassium pump. So these ions are going through the cell and changing the polarity of the cell, causing a big spike in energy, and that energy can then be conducted. So that's the second characteristic of heart cells. It can be conduction. Now, I ain't no spelling champion, so you'll keep your comments to yourself. So automaticity creates electricity. Conduction means it can transfer that energy to the cell next to it. Next, we have excitability. What does it mean to be excitable? Well, I'll give you an example. If I was to tase a rock, you wouldn't see much happen because it's not very excitable. The rock doesn't have the characteristics that make it excitable. But if I had, let's say, well, I got Ben in here. If I had Ben Blackwell, who's in the class here with me, if he was in the bath and I just jumped in there and was like, "What's up, Ben?" Then I tase him while he's in the bath. Would Ben be excitable? Yes. Yes, Ben would be excitable. He would be quite excitable. Probably one, because somebody jumped in the room with him while he's taking a bath and it would excite him. Two, because someone's tasing him for not making a 99 on a test or something. You know, these are real threats. So excitability is the ability to be stimulated. And next we have, and finally we have contractility. Contractility. So we got automaticity, conductivity, excitability, and contractility. So does dead meat beat? No, it does not. So a heart that has got damaged meat and damaged tissue will do what? It doesn't have the elasticity to squeeze and pump blood anymore. So the heart loses a bit of its stroke volume. Stroke volume is the amount of blood that comes out with each contraction. It may lose some of its ejection fraction, which is the amount of blood that comes out expressed in a fraction. So dead and dying heart tissue is a bad idea, okay? So what is the end all goal for these patients? Well, let's talk about that. Is that while you may be super EMT and I might be super medic and stuff, there is nothing we can do but buy the patient time. In regards to a patient having a heart attack, there's some kind of supply and demand issue. Let's say this is a big old vein and artery here. All right. And the issue is what? This big old mass of fat right here, blocking this heart tissue from getting the blood flow it needs. What can you in EMS do about that? And the answer is not a lot. You can give nitroglycerin to widen this vein or artery up and allow more blood flow to go to that area and reduce the workload of the heart. That's an option. Aspirin can stop the clot from getting bigger. Aspirin stops platelets from sticking together, so it doesn't break any clots that are there. It's not a blood thinner, but it will stop the clot from getting bigger. And there are studies that collaborate that show that if patients receive aspirin earlier in their myocardial care, then they have a 25–26% higher chance of surviving the attack that they're under, the heart attack, the MI. So there are things you can do, but what this patient really needs is a cath lab. A cath lab is where a doctor, a cardiac interventionalist, will actually look into the patient's heart, will do an angiogram, and they'll insert a wire in the patient's either radial artery or femoral artery in their leg, and they'll inject dye. The dye will show the cardiac interventionalist what percentage of the heart is blocked, what coronary artery is blocked, and it'll give them an idea of what plan they need to make to fix it. Now, sometimes there is just too much blockage here to do anything about. But sometimes what they can do is actually stab a wire through the clot, inflate a balloon, and snatch the clot out. That's an option. Another option is what? They can insert the wire over here to this little area of the blockage. There's enough room here where they can stop here and inflate the balloon right here and squish all that yellow clot mess down. So they've inflated the balloon and squished the clot down. That's an option. They'll then place what's called a stent, which is kind of like a mesh straw. It's kind of like a mesh straw. And that stent will be right here and allow for blood to flow through here to get to the heart versus, no blood flowing, which is going to kill the patient. Now, what if there is a complete blockage? What if we just got just a huge blockage like right here? So at a certain point, there's nothing the cath lab can do. The patient will actually need open heart surgery. They'll need a CABG, C-A-B-G. Let's do that together. C-A-B-G. We call it a CABG. Stands for coronary artery bypass graft. Coronary artery bypass graft. So that means they're going to take a vein from the patient's leg. All right. And what are they going to do? They're going to actually bypass this clot. And blood can actually flow around this issue. Blood can actually flow around the clot and feed the heart what it needs. Now, can you do any of that in the pre-hospital setting? And the answer is no. Again, we have things we can do, but in the grand scheme of things, that patient needs reperfusion therapy, and reperfusion means that there's blood flow returning to the heart, restored to the heart, and that is provided by a cath lab. So any cardiac chest pain patient you have, you need to be on that scene for 10 minutes or less. 10 minutes or less is how long you need to be on that scene. You need to be placing that patient on a 12-lead EKG within the first few minutes, like 2 to 4 minutes of meeting them. So that'd be something like that along those, hey, sir, you got chest pain today? Hey, my name's Josh. I'm going to go ahead and put these stickers on your chest, buddy. Okay, we're going to take a look at your heart. Please don't move while I'm taking a picture. Something along those lines where you can get a clear and concise picture, because there are things that can throw the cardiac monitor off. Things like 60 megahertz interference. You ever been next to a power line and heard that little humming? That can throw off your cardiac monitor. You ever sat in the back of one of these ambulances and you felt the diesel engine kind of thrumming underneath your feet? There was a low vibration. That can throw off your 12 lead. There's a lot of different things like artifact that can throw off your 12 lead. So getting a good baseline set of vitals and 12 lead right there on scene while the patient ain't moving, while you're getting a history, is going to be very, very vital to your success. Now, is taking a 12 lead the end all be all this patient's having a heart attack, an MI? Is it? The answer is no. I don't never understand why some paramedics are out here playing God with patients. He ain't got nothing wrong with him. He's full of it. You don't know that, sir. You don't know that at all, because the truth of the matter is that only about 44 to 47% of patients will actually exhibit EKG changes in the presence of a myocardial infarction. Why are they exhibiting these changes? Well, the problem we're going to have is that the electricity cannot travel through the dead meat. Does dead meat beat? Does it conduct? Does it excite? It does none of it. So water, air, electricity all follow the path of least resistance. When you see an ST elevation myocardial infarction, it's because the electricity has hit a level of an area of dead meat and found a way around it. It found a pathway around it. So that's why you'll see EKG changes. Now, that's not going to occur, but only in about 44 to 47% of your patients. So what are you saying, Josh? Is that a 12 lead can't really tell me if a patient's having a heart attack? That's exactly what I'm telling you. Do not play God with your patients. How do you know if a patient's really having a heart attack? You take some blood. You run it through an iStat or a little machine that's going to calculate their troponin levels. You see, when the heart is under stress and it's got dead and dying tissue like that, it will release chemicals that can be picked up by a simple blood test. If there's an elevated troponin level, that means the patient's having a heart attack. If there's not, it might have been hot wings and gas or some type of thing like costochondritis, pericarditis, myocarditis. There's all kinds of things it could have been other than the patient actually having a heart attack. But in the field of the pre-hospital, that's mine in your area, there's no way for us to really know. So if they say chest pain, you treat them like they're having the biggest MI in the world, and you treat them with respect and don't get weary in doing well. What does that mean? Sometimes we pick up a lot of patients that we see a lot. There was a guy that was a homeless guy that I picked up 2 or 3 times a week back when I was on the streets. And I knew he was full of crap. He just wanted to flirt with big booty nurses and get a turkey sandwich from the ER. I ain't mad at him. It sounds wonderful. However, I always treated him like he was having the biggest MI ever. I gave him a 12 lead. I started an IV. I gave him nitro. His blood pressure was high anyway. It's not going to hurt him. I gave him aspirin. It's not going to hurt him. I followed my procedures. One day when I picked him up, my spidey sense was tingling. One day when I picked him up, I could see a difference in his facial expression. I could see a difference in the way his eyes were being held. There was something up with my guy. What did I do different? Not a thing. I treated him like he was having chest pain. And guess what I saw? On the 12 lead, he was having the biggest inferior MI. Big old MI. We're talking about tombstone ST elevation. Tombstone's very poor prognosis for a patient. So they're called tombstones because the ST elevation actually looks like a old-fashioned tombstone. Guy was in a bad shape. I called the cath lab and he was on the table in 10, 15 minutes. And he got a couple stents that day. He lived another 10 years. What would have happened if I'd have just, oh, it's just old fella here. I see him every week. Just get in the truck. Let's go get some turkey sandwiches. He probably would have died. Try not to play God with your patients. I don't care how burned out you may be, which is, it's crazy because some of you are in the A class and like you come in there complaining like you've actually ran some calls. Like, give me a break. Literally, give me a break. You haven't ran any calls. When you're like 14 years in and you run 12-hour shifts and run 17 to 20 calls, then come holler at me. You got it easy. Relax. Enjoy it while you can, because one day you'll be like me. Here I am teaching you, and I'd give anything to be on the truck again full time. Because looking back over my shoulder at that, it was a true privilege to be able to serve the communities I did. Now I serve a different capacity. I'm here with you, trying to make you the best thing that you can be. I don't want to turn you into me. I want to turn you into you. I want you to be the best version of yourself. So I'm not training partners anymore. I used to be a paramedic instructor that trained people that I'd work with. Now I'm training replacements. Therefore, you must be ethical and you must not skip boxes. You must check every box and be thorough. You want to not mess up at this game? You want to do this right? You be thorough, head to toe every time, even on medical patients. Why medical patients? Even on a medical call, going head to toe and doing a physical assessment, you'll find things like insulin pumps, fentanyl patches, nitro patches, open septic wounds. You will find things if you are looking for them and you're being thorough. My advice to you, young Padawans, is to be thorough. Be extremely thorough. All right, so we're still talking about being thorough. That's what we want to do. So moving on to specific, how do I treat a chest pain patient? Because there are different modalities based on level, like from the B to the A to the paramedic level. Well, let's talk about it. So first off, let's remember that there is a thing called a silent MI and also a non-STEMI. So non-STEMI stands for non-ST elevation myocardial infarction, which means there's not going to be EKG changes. Again, that happens only 40-something% of the time. And what about a silent MI? A silent MI is a patient that doesn't even have chest pain. Did you know that patients can have an MI and not even exhibit chest pain? Well, there's 3 groups of patients that usually happens to. So we have the elderly, diabetics because they have autonomic dysfunction, and women. Sometimes a woman or elderly or diabetic, they won't even have chest pain. This is why I 12 lead everybody. I'll give you an example. I go to Meemaw's house. I just feel weak today, baby. Golly. I put her on a 12 lead because I'm being thorough. And there it is, a beautiful ST elevation MRI. Well, no wonder you're weak, Grandma. You're having a heart attack. Am I, baby? I mean, yeah. Get in. Come with me if you want to live. So Grandma's having a heart attack. But again, women, elderly, and diabetics, they don't always present with chest pain. They may have something else like difficulty breathing. They may have like, my back hurts, or I feel weak, or they might have a pale ashen gray or mottled appearance to their skin, where their skin looks kind of patchy. Again, it's a perfusion issue created by the supply and demand that they cannot really meet. So keep that in mind as we move forward. Now, how do we treat chest pain patients? Well, again, the first few minutes you being there, you should be popping them on a 12 lead. You should be pointing that ambulance towards a cath lab. So that means that some hospitals are not good hospitals to take your patients to. One of the biggest and best things you can do for your patient is to pick the right hospital. You pick the wrong hospital, you could have signed their death sentence. I'll give you an example. If I have a chest pain patient and I take them to Grady, they got a cath lab, not a big deal. If I take them to DeKalb Medical or Emory DeKalb, I have just killed them. Or Hillendale, also known as Killendale over there in DeKalb, or Southern Regional, dead, and dead. You might as well just kick them out of the moving ambulance at 70, 80 miles an hour. It's quicker, less paperwork. So picking the right hospital that has a cath lab. So one of the things you must master as the EMT, AEMT, paramedic, whatever, you must master your service area. What does that mean? That means I know which hospital to take which patient at which time. This is a stroke patient. I got to take them here. This is a heart attack. This is a chest pain patient. They got to go here. This is a trauma. So let's say you go up there riding Forsyth, right? In the Forsyth 911 market. Well, Forsyth 911, they've got one hospital in that town, and it's for Northside Forsyth. They do have a cath lab, but they can't handle trauma to save their life. They about cried one day. I brought a broke leg in there. They're whining about it. Why didn't you go to the Roswell? Because he wanted to come here. I can't kidnap him. Rona. So choosing the right hospital is very important. Now, I don't want you going around pissing off nurses, but there is a law called EMTALA. If you go to a hospital and they're like, we're full, blah, blah, that's a courtesy. As soon as you hit hospital grounds, that is their patient legally. They cannot turn you away. They must treat them. Now, I'm not telling you to do that except under dire circumstances, but if everybody's on diversion, nobody's on diversion. I was working in Atlanta at Grady when that Grady's ER flooded, and everybody was all pissy about, having to go to this ER. I'm like, Grady's shut down. They take over 1,000 patients a night. You're it. I'm sorry. I don't mind sitting over here. I don't care. I mean, the patient wanted to come here. There's nowhere else to go. Also giving a radio report, letting them know you're coming. It's not a law. It's a courtesy. It's a courtesy you should observe. It's a courtesy you should observe, but it is a courtesy. So what would be the benefit of actually calling ahead? What do you think there, Zachary Heller? I'm going to assume nothing. What about you, Christina? No, I don't want you. Christina Shane, what would be the benefit of me calling ahead? I'm hoping it's a good thing I'm recording this for some of y'all because y'all are not participating. All right, iPhone, you can go.
So you're basically letting them know exactly what to expect. Number one, anything that you have done in the back of the truck, any changes, like with the patient status en route to the hospital, and I think that's about it.
Okay, so you're telling them what you were called for, what you saw when you got there, what you did about it, what you got now, basically.
Yes.
That's what's happening. But also, you're giving them the opportunity to allocate resources for you. If you got a trauma coming in, they need to have the trauma team ready. If you got a stroke coming in, they're going to have the stroke team ready, cath team ready, or whatever. You're giving them the opportunity to get you a room ready for whatever. So you give them a heads up, they can have you resources ready. Much better for you and the patient to do so.
I didn't realize I was muted.
Sure you didn't. You weren't playing Call of Duty or something else. Whatever.
Happens to the best of us.
It's okay. I'm not offended.
Oh, I knew I was muted because I saw him say, "Oh, Josh muted you."
Anywho. So yeah, we want to get them to allocate resources. Would you like an example of a radio report? Okay, I see Ben's asking for one. So Med 1 to Grady. Grady, go ahead, cut your truck off. Med 1's en route to facility with a 65-year-old male patient complaining of chest pain that substernal radiates to his left arm. Patient has had the pain for about 2 hours now, has a history of coronary artery disease and hypertension, non-compliant with his medications. At this time, he's been given an IV 18 gauge in the left AC. Patient's been given 3 nitro 0.4 at this time. Patient's been given 324 of aspirin and 50 mics of fentanyl. Patient's vitals are as follows. ETA is 5 minutes. You're going to want it to be 20 seconds or less, and you're going to want it to be pertinent. They don't need to know the patient's whole life history and like they had a hysterectomy back in 1940, but it needs to be pertinent information. It needs to be like succinct. Identify who you are, identify what you're bringing, identify what you've done about it, identify what you have now and how long before you hit that ambulance bay. Does that make sense? Ben, did that get what you wanted? Let's see our chat bubble. Perfecto. Cool. Yeah, just keep it simple. And I to be honest with you, my radio report is a compilation of like 4 medics that I idolized when I was a young warthog, when I was younger. So Martin Wise was my preceptor. Then that was with Stu Harding, and then the supervisor that I started working under was Lee Hughes, and then Todd Shuffleberger. About those 4 guys, they had different ways of doing their stuff, and I was like, that's useful. That's useful. This is now mine. So I found my own way of doing things, but I ain't gonna lie and say I didn't have influences. Is that required every time you go to the ER? Again, it's not a law to do it, but it is a courtesy, and a courtesy that you're going to want to give the nurses. So it's best if you go ahead and you stay in the good graces of the nurses you work with. So I would say yes, I'd want, and especially if you work for a private service where you got to kind of mind your P's and Q's, it's a good idea to do it. What are some of the common mistakes you see when or have made when coming to the ER? So common mistakes I see is people not checking small things like blood sugars, not running a 12 lead, having a trauma patient and you didn't cut their clothes off. That's a big deal, because you know how silly you would look and how bad your service would look if you'd have just cut the person's pants or whatever off. You'd have found the bullet wound and now they're sitting there bleeding and their blood pressure 60/40. I saw this happen at Grady and it wasn't pretty. They cussed that medic up and down, and it was an AMR crew, and like they just told him how it just wasn't good. So diversions are a courtesy. Yes, it's no law that says you can't go there. They have an EMTAL law that says you can show up and it's their patient once you're on hospital grounds. Now, we do try to honor diversion because we don't want to delay the care the patient's going to receive. If like at Grady, there's been nights where they have like 8-hour waits in the waiting room, but that's because they're always triaging. Yes, your toe hurts, but this guy came in and he can't breathe. He's going to be up triaged and he's going to be treated first. I cut the clothes on every trauma scenario, unless it's like an isolated trauma, like pretty much like stub toe. So diversion is a courtesy, but it's a good idea for you to actually do it and try and abide by it if you can. What's the difference in radio report and bedside report? Okay, struggling with both. All right, so a radio report, again, is just giving them 20 seconds of kind of a summative report of what you have going on. So at that point, with a radio report, you're just trying to get them to allocate resources. I'll give you an example. Med 1 in reactive facility with a 65-year-old male patient in full cardiac arrest. ACLS protocols have been followed. Patients intubated, IVs in, three rounds of epi have been pushed. ETA is 5 minutes. What did I just do? I told them I had an elderly patient. They're in cardiac arrest. I've got ACLS protocols kicking. Only thing that we have to do when I get there is do what? I've got the tube. I've got the line. I've got drugs pushed. We just have to continue the cardiac arrest protocol. Nobody has to worry about intubating. They know that. They don't have to worry about getting a line. They know that. They can get a second line if they want, but they know that. And it was all done in like 10 seconds or less. Now, when you get to the bedside, now it's time to lay out the old everything. Patient has had a hysterectomy in 1945, blah, 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 blah. I prefer myself to stay very, very close to pertinent information. Like, patient was, good evening, everybody. Is everybody listening? You get their attention first. You take over the room with your voice. Make sure they're ready for you. Shut them up. All right, everybody ready? All right. So this is a 22-year-old male patient with an allergy to peanuts. Patient was eating some pizza that had peanuts on it, developed a scratchy throat, felt like his throat was closing up, laryngeal edema. He has erythema, hives and itching, developed some respiratory distress. Patient was treated with this. We've done this. And you just lay out a story. You tell the full story then. But a radio report's just a, hey, here we are, 20 seconds or less, get this resource ready for me. Does that make sense? And Ezra, I try and cut close on every trauma patient if I can. If it's super isolated, like stub toe or like just a broken ankle, I'll look up in the leg a little bit more. But if I can say, I mean, again, you don't want to just destroy people's clothes if you ain't got to. Like, clothes is expensive. You know, nice clothes anyway. You know, none of the ones I have, but you know, shop at Goodwill. So if you can save somebody's, you know, brand new tennis shoes and stuff, take the shoes off. You don't have to cut them off. If you can take them off without damaging anything, then do that. And if you can, you know, get around them, do that. But I would say be thorough and don't get caught with your pants down. By that, I mean, don't miss something because you didn't look. These are good questions. Not a bad segue. So how do you treat chest pain and why are you doing it? We have a pharmacological response to chest pain in chest pain patients. So depending on what level you are, at the A level, you can give drugs. At the B level, you can assist in giving drugs. So the first one we're going to talk about is ASA. That's aspirin. It's also known as acetylsalicylic acid, ASA, or just aspirin. It's got several different names. And if you caught the pharmacology lecture I gave, really have to know the generic and the brand name so you can recognize them on registry. One of my students this last year, he had a patient that had overdosed on sildenafil. Now, he knew what sildenafil was, but he was also an older male. Sildenafil has another name that we would all know immediately. It's called Viagra. So luckily he knew what that meant, but you know, some of us wouldn't have known that one. But it's good to have knowledge of several different names for different drugs. Like fentanyl is also known as sublimase. You know, ketorolac is also known as Toradol. You know, acetaminophen is Tylenol. Diphenhydramine is Benadryl. You have to know at least both those names so you can identify them, because registry is real big about using the more complicated term. They're not going to say patient can't breathe. They're going to say dyspnea. They're not going to say kneecap. They're going to say patella. The stronger your medical terminology is, the better you'll be on registry. So aspirin, we give this to patients as long as there's no contraindications. Contraindication means why you would withhold it. The dose for that is going to be 324 milligrams orally. That means you give it to them by the mouth. That means that they can chew it up and swallow it. The sooner you get the aspirin in them, it gives them a higher chance of not dying because it can keep the clot from getting bigger. What if they ain't got no teeth? Well, the baby aspirin can dissolve. You know, just put it in their mouth, let it dissolve, and they can just swallow it when it's dissolved. So aspirin's your first round drug. Why would you not give it? Well, if they got a history of stomach ulcers or an active bleeding ulcer, you would give it. What if they're like, I just don't like the way it makes me feel? Well, that's too bad. Eat this. At some times we have to kind of choose between life and limb, you know, and if there's not a good reason to withhold it, I'm not going to. All right, the next drug that we can give or assist in giving is going to be your NTG, also known as nitroglycerin or nitrostat. So this drug's very, very potent. Very, very powerful, and it can cause a lot of damage if you ain't a lot of careful. Before you give any drug, you should observe the 6 rights of medication administration, which means that you are making sure it's the right patient, the right route, the right time, the right drug dose documentation, because these drugs do expire. So make sure the drug's in date, make sure it doesn't have floaties in it, make sure it's not like damaged or turning colors, and make sure it's the right drug. A lot of these little vials, they look the same. I'll give you an example. Zofran looks a lot like Benadryl because they're both little blue vials that come in the med box. At least at Grady they do. And I know a couple times I'm like, whoop, that's the wrong one, because I checked. Before any drug is given, for me, it has to go between 3 barriers. I look at it, my partner looks at it, and I look at it again. My dad used to tell me when I'd help him do construction on the summers, measure twice, cut once. Because if you cut one of these boards and cost me money, I'm taking it out of your paycheck. That was very motivating for me to not make a mistake on cutting the board. So the dose for that is going to be 0.4 milligrams. 0.4 milligram tablets. They go underneath the tongue. They're sublingual. What if you give it to a patient and they just swallow it? It will not work. The nitroglycerin will be eliminated by the first pass metabolism in the stomach. It will not even do a thing. It'll be eliminated, inoculated. It will become ineffective by the stomach acid. It has to be given under the tongue, and that mucosal membrane will absorb it in a few minutes, and it will hit that bloodstream, causing vasodilation, so skinny to wide pipes. More blood can flow to the heart, and the workload on the heart can be reduced. You can give nitro 3 times, so 0.4 times 3 every 5 minutes. Now, nitro is a dangerous drug. If you're at the A level, I do not let my paramedics or my A students give it unless they have an IV line established. I do not let them give it unless they have done a 12 lead, because an inferior MI where there's a blockage in the bottom of the heart, if you give them nitro and bottom their pressure out, you could kill them. Nitro is very dangerous. It's best to have a 12 lead, and best to have an IV in case the pressure bottoms, and you can at least push it back up with fluids or a pressor if your paramedic is present. So nitro 0.4 times 3 every 5. Before you give it, check a blood pressure. After you give it, check a blood pressure. You also must make sure the patient has not taken any erectile dysfunction medication. Yes, due to the reduction in preload. So for patients with a inferior MI bin, they're going to need a full tank. They're going to need all the blood they can get coming back to that right side of the heart, because the inferior MI is usually fed by the right coronary artery, and reducing blood to the right side of the heart will cause it to not have any, and it'll just kill you faster. So they need a full tank to survive. So aspirin, nitro. What about oxygen? Having those free-floating oxygen molecules going in the body, increasing the concentration of oxygen in the bloodstream, can help the patient. By giving them a higher concentration, they have improved oxygenation and they have more of a supply in their body, because what's the problem with a chest pain patient is what? They have a supply and demand issue. You are trying to give them more of it. I got a question. What if a patient refuses meds for no good reason? That's a great question. As for me in my house, we're going to do the right thing. I at least offered, I will document that he didn't want it, and I'll make him sign a refusal. I will put in the refusal section, patients refusing meds, but not transport. And then I'll have him sign that, saying that he did refuse all care except transport. Does that make sense, Stephen? Yes, sir. And that's completely okay. I've had patients that would allow me to give them aspirin, but they didn't want the nitro because they might have been full of poop. They might not have actually been honest in their intentions about having real chest pain. Well, it gives me a headache, and they do it every time, twice a week. Well, buddy, I'm not going to force it down your throat, but if you are actually having a heart attack, and this will save your life. But if you don't want it, I just need you to sign here saying I at least offered it so I don't get in trouble. Can you do that for me? All right, I appreciate you so much. And also making sure that they're not on those erectile dysfunction medications. Why? You give them nitro and they're on erectile dysfunction medications, it will kill them. So death before dishonor, men will lie. So if he's out with a young, pretty looking little girl, Separate him from her because he'll lie. He'll die right in front of her. He won't tell the truth. Separate him. All right, bro. You tell me now. If I give you this pill, it's gonna kill you. All right, player. I'm on it. Don't tell her though. I got you, fam. You telling nobody. So just separate them, talk them out. Why does the combination of the two cause death? Okay. So for example, Viagra was actually created for pulmonary stenosis and pulmonary hypertension. It was made as a drug to reduce high blood pressure on the right side of the heart, like pulmonic valve stenosis, to be exact. And and it was also great for babies that have pulmonic valve stenosis. They were born with a kind of a narrow pulmonic valve, and it widens it open. Holy crap. And it widened it out. So while they were giving babies this medication, they noticed it had one hell of a side effect. Okay. So that side effect was something like that. A blue vein throbber. All right. So quite the side effect there. Okay, Ezra. And because it has the capability to lower blood pressure so itself, and because it's a phosphodiesterase inhibitor, it can precipitously drop the blood pressure on the floor. So if they've had an ED medication within 24 to 48 hours, it's still floating in their system. It could kill them. That answer your question? Yeah, man. All right. So is that where the myth of Viagra helping at high altitudes comes from? Probably that's where it comes from. But there's lots of myths down here that I don't really prescribe to. Like my mother's upstairs, and like she swears vinegar can fix anything. In South Georgia, if you broke a leg, Robitussin. If you had a cold, Robitussin. If you were dying of COVID, Robitussin. Can't believe everything you hear. We believe in evidence-based medicine, where 10 out of 10 times the evidence doesn't lie. So O2. All right, so aspirin, nitro, and O2 are what we're going through. So that's our go-tos for treatment of chest pain. Again, you're going to want to do what else? Part of your treatment should be to check a blood sugar, run a 12 lead, but also call the cath lab. So the cath team is not usually just sitting in there waiting for something to do. They're usually doing other things, and they have to be called, and they have to be brought together. So you're going to want to call them as soon as possible. And if you have capability to transmit your 12 lead to the ER, then you do that. Transmit your 12 lead to the ER. What does it mean to transmit? It means to send it kind of like a text message off to the ER. And then a cardiologist can look at it and see what kind of other ectopy or funny little beats are located there. All right, so other issues we could run into will be hypertension. Hypertension can cause an aneurysm. Aneurysm is pretty much a weakened area of a vessel wall, either in the brain, or most of the time it happens in the abdominal area. So a AAA is an abdominal aortic aneurysm. So basically, most of the time it's from patients having a weakened vessel wall, but most of the time it's from chronic hypertension that's left untreated. So chronic hypertension left untreated. So they left the pressure in the system's too high, and it normally forms a bulge on the aorta. And as it forms a bulge, that it'll eventually burst. And if you have a AAA, you'll know it because the patient will die right there. You could have a AAA on the operating table and still probably die. It's very bad news. So how do you recognize a AAA? They'll complain of chest pain that radiates to their back, and they'll complain of a tearing sensation. This is why it's important for you to get a history. Describe the pain to me, sir. Well, I feel like my back, it feels like it's tearing apart. Ooh, scary. Then we'll take blood pressures in both arms to see if there's a difference, because the aorta, it splits and goes left and right and feeds the brachiocephalic arteries over here. And you would see a difference in blood pressure if they have a AAA going on. They'll complain of chest pain that radiates to their back, tearing sensation, different blood pressures in each arm some of the time. They'll also feel like they have to defecate, like I feel like I got to poop, but I don't have to poop. That's because blood is dripping out of their aorta, and it's dripping at the bottom of their stomach and their peritoneum. They feel that urge to push something out. So what do you do about that? Well, that's a good diesel bolus, because faith, hope, love, diesel bolus is what you got to do. They need to be in the presence of a cardiothoracic surgeon as fast as possible. At the A level and the B level, there's nothing you can do. And then even at the paramedic level, there's not a lot you can do. But what can you do? Relax them. Hey, bro, chill out. Bring it on down now. Now, the other place an aneurysm can happen will be in your brain. You can have an aneurysm in your brain. A vessel will pop and you'll have bleeding in your brain. They'll have a hemorrhagic stroke, a stroke in the brain. So looking out for signs of that, you'll have a patient complain of the worst headache they've ever had, and then they'll exhibit stroke signs. About 15% of strokes are hemorrhagic, where a vessel up here popped. Most of the time it's because people don't take their blood pressure medicine, do not take their health serious. So those are very avoidable things that could be avoided. Any questions so far? Really? All right, so next thing we'll talk about is the congestive heart failure. Is there a way to determine, let's see, is there a good way to determine between hemorrhagic and ischemic strokes? You know, buddy, there's not a good way in the field. What has to happen before they even treat a stroke in the ER is that they have to do a CT scan. So a CT scan takes a look at the inside of their brain, and then they can determine, is it an ischemic stroke or is it a hemorrhagic stroke? So that's why it's a good idea to go ahead and call the stroke alert and take them to a stroke center. That way they can do the CT scan, then they can treat, because if it's a ischemic stroke and there's a blockage, they can give a clot buster called tissue plasminogen activator, or TPA. Now, TPA will bust every clot you ever thought about having, but they have to meet certain criteria to get it. And if they gave TPA to a patient that had had a hemorrhagic stroke, it would just go ahead and kill them like that. So they have to do a CT first. There's no good way for you to determine. If you see stroke symptoms, though, I can give you this bit of information. If a patient has even one of the three main stroke symptoms, like when you do the Cincinnati stroke scale, you're talking about facial symmetry. Smile, sir. So the face is drooping. Arm drift, if they have an arm drift, like one arm's weaker than the other side, or speech issues where they can't say things, say words very good. They have dysarthria or slurred speech. If they have even one of those signs, there's a 72% chance they're having a stroke. That is a Googleable fact. Googleable fact. So I have taken patients into the ER that I called a stroke alert and it was some other kind of neurological thing, but how was I to know in the field? It's better to call the stroke alert or call the chest pain cardiac cath lab alert and be wrong about it than not call it and then the patient have something bad going on. Nobody will call you a bad medic or EMT for calling the alert and just being sure at all, even a little bit. Do it and be wrong and have the patient have a good outcome. That would be my advice. Everybody feel me? I love it. All right. I'm gonna, let me see. So finishing up with our cardiac lecture, we have other issues we would run into, which would be left-sided heart failure versus right-sided heart failure. So with left-sided heart failure, what we have is decreased stroke volume, so that left ventricle cannot push out blood like it used to. Perfusion in the patient will be reduced. They'll have pulmonary hypertension that'll occur. They'll have fluid in alveolar sacs. They can't lay flat because again, they'll have paroxysmal nocturnal dyspnea, so trouble breathing while laying flat at night trying to go to sleep. And they will have very poor prognosis for a long period of time. You know, it's usually a terminal disease that they will need a heart transplant at some point. So left-sided heart failure is wet, which means that there's wet lungs with left-sided heart failure. Now, right-sided heart failure is usually due to the right ventricle unable to sustain preload, and it backs up into the peripheral venous system. So they'll have JVD. There's a fun trick you can do with their liver. You can push on their liver and you can see their JVD pop up, and they'll have peripheral edema. So they'll have sacral edema. They could have ascites, which is edema in their stomach. They have a big old water stomach. They'll have fluid in their feet, and where they're real puffy, you can actually push on it and leave a mark. The number one cause of right heart failure is left heart failure. The number one cause of right heart failure is left heart failure. It can also be hypertrophy of the right ventricle, a right ventricular infarct, so a right-sided MI, things like that can do it. Now, left side of heart failure is wet, right side of heart failure, your lungs are dry. Now, left side of heart failure, the number one cause of it is a left-sided MI, so a heart attack that's damaged the left side of the myocardium. Now, these both issues can cause what is called cardiogenic shock. Now, shock is hypoperfusion. Hypoperfusion means that there's a lack of blood flow to the cells making the tissues making the organs making the organ systems making the organism, which is you. So that lack of blood flow is caused by something. It'll either be a pump problem, cardiogenic shock, a low fluid problem. So maybe I stab you and you leak out. And so that'll be hypovolemic, low volume shock. Or it could be big space shock where there's a pipe problem. 3 examples. Anaphylaxis causes the pipes, the veins and arteries to do what? Vasodilate. So the pressure in the system falls. When the blood pressure falls, now you're in shock because you have to have a certain pressure in the system to hit the target cells. An example I like to give is that if I had a water hose right now, I could spray that wall right there in front of me, but across the room, I couldn't do it because I don't have enough pressure. So I narrow the flow by putting my finger on the end of the water hose. It increases the pressure and I can reach that wall over there. So I have to have enough pressure in my system to reach my target cells that might be farther off in the periphery. So when the blood pressure falls, we're in some type of shock. Is it a pipe problem? Is it a pump problem? Is it a volume problem? Another pipe problem will be sepsis. Sepsis causes bacteria to be released in the bloodstream due to a wound or some type of induit, like let's say it's a catheter. Anytime you go to a nursing home, expect sepsis. So they have bacteria in their body. The body has a pyrogenic reaction, which means they're going to have a fever. It's the warm shock. They're warm to the touch. Their blood pressure's on the floor. They're sick as a dog. This will kill them because they're not getting enough blood flow to their organs. The organs will have the tissue die, and the organs will then shut down in what's called MODS. Sepsis can cause MODS, multiple organ dysfunction syndrome. So that's another big space shock. Another third one is a neurogenic shock, where a patient has a spinal cord injury. They lose sympathetic tone. So the adrenal system, which keeps everything tight, is now not there to hold everything tight. So it's got wide, big pipes, and the patient's now in shock. Now, cardiogenic shock is when the pump, the engine, is not good enough to run the show. It cannot meet the metabolic demands of the body. That patient needs to be put on a blood pressor. So some type of pressor drug like a alpha agonist or something that can constrict the arteries and raise the blood pressure. That's a paramedic skill. You're going to need to call ALS or transport them to an ER that can get that blood pressure up. So you need to transport them rapidly, position of comfort, oxygen, sit them up high. If you can start an IV at the A level, you can. At the B level, you can at least set it up for your paramedic or your A, and that's what you got to look at. So there are 3 different types of angina. Angina is a fancy word that means pain in the chest. A-N-G-I-N-A, angina. So there's stable angina, there's unstable angina, and then there's variant angina. If you're taking notes, I'll say it again. There's stable angina, unstable angina, and variant angina. So stable angina is this is Peepaw out in the yard. He's pushing that push mower, and you done told him not to, but he's impatient. You done told him, Grandpa, I'll come cut the goddamn grass on Saturday when I'm off. But him being impatient, old fart, wants to get out there and push the grass, the push mower, and now he's over there with chest pain. Why is he got chest pain? Why does his chest hurt? Because he pushed his body, and his old heart cannot pump enough blood to feed itself. So he's going to have chest pain. Stable angina is the patient's usually doing something they ain't supposed to, like exerting themselves. It lasts 3 to 5 minutes. And if they sit down and rest or pop a nitro, it goes away. That's stable. Unstable angina is the patient can be sitting there watching TV. Oh God. And their chest starts hurting. And it lasts over 20 minutes. And nitroglycerin that they are prescribed is not helping. That's unstable when nothing's helping and it's getting worse progressively. Finally, we have variant angina, also known as Prinz metal, P-R-I-N-Z metal angina, Prinz metal or spasmodic angina. This is when the coronary arteries have something piss them off and they collapse, they close, they spasm shut, so blood can't flow to the heart. The number one cause of variant Prinz metal angina is drug abuse. A lot of times it'll go away spontaneously, but drug abuse can cause this. Number one drug that causes it, cocaine, the sugar of the South. Cocaine is the number one drug that causes it. It'll cause that coronary artery to spasm close and no blood's going there. Oh, my chest hurt. I'm feeling kind of funny because you're dying. Congratulations, you played yourself. So that's what I'm going for. So I got some questions. Sounds like my family. Hell yeah, I got drug addicts in my family too. I think most of us could be like, yeah, we got some stuff. Is angina even recognizable? No, angina is just they tell you they got chest pain, which is a subjective, subjective collection of information at that point. You can recognize if a patient's having ectopy on a 12 lead. You can note the presence of an infarct. You can also note the location. You can see a bunch of other little things, but angina is subjective to the patient if they have chest pain or not. And again, not every patient will have chest pain and still can have an MI without having chest pain. You can have an MI without showing 12 lead changes. How do we know the patient's actually having a heart attack? Well, blood tests. You don't do that in the ambulance. Don't get me wrong, there are some ambulance services that carry an iStat. They can do troponin levels right there in the truck. But even a used iStat is like $20,000. You think they're going to spend that kind of money on you? No, player, no. So if a patient says chest pain, you believe them. I got a question there. Let's see. Is it going to be a large amount of cocaine or any amount? And what else can cause the pain besides that? So I don't want to help you figure out how much cocaine you can take before you have chest pain. So I'm not sure I should answer this one, but it would be variant based on the patient's reactivity. So it'd be based on your tolerance for it. You know, if you just take a big lump of it and it can spasm you close. So it'd be different for every patient is what I would surmise. That is what you meant. You're trying to figure out how much drug you can take. You're lying. I see you. Can an inverted T wave cause concern? Yes, inverted T waves are one of the first signs we can see on an EKG that the patient's experiencing ischemia. It's also what we call a reciprocal change because the heart mirrors itself. Like an inferior MI is the bottom of the heart will mirror kind of the lateral side part over here. So if I'm actually having an inferior MI or a heart attack on the bottom of the heart, the lateral portion over here should actually mirror it and show some inverted T waves. So it's a great way to verify that you are having an MI, and it's also a way to see that their patient could be having some myocardial ischemia. All right, another question I got. Let's see. It's an early warning sign that if they have inverted T's, that it could graduate to the ST elevation segment, elevating and them showing injury, then infarct. Yes, sir. It's an earlier sign. Infarct, elevated T, but I saw a depressed T. Yeah, so depressed T waves are another reciprocal sign and could have a lot to do with ischemia. These are good questions. They're paramedic style questions, but I don't mind at this point. All right, other questions. This is open Q&A time. I'm kind of done with my lecture. I'm getting tired. I'm sick of all of you now. So, cardiology, chest pain, the EMT, the EMTA, the EMTB. You've got a couple of drugs you can give. Main thing is don't play God. Get troponin levels at the ER. Give the drugs you can. Take them to a cath lab. Spend 10 minutes or less on scene. You should be in good shape. That's summary of everything I've said pretty much. Come on, other questions while you have me. It's not often we get to hang out together. This is your time. All right. What calls can we expect in our clinical ride-alongs? Well, Buddy Rowe, that is the fun thing about EMS is that you can never, ever predict what's going to happen. There is data that can be looked at to see that, like there are geographical areas that have a higher call volume for this type of emergency. And like I can tell you, like winter in Atlanta is like respiratory season, and the summertime is trauma. So you're going to be doing a lot. It's hot, and people get pissed off when they get irritated and hot. So yes, you will run more trauma, at least in the Atlanta area. And if you're riding third rides in Forsyth, they have a lot of cardiac up there, because it's a old country county. They got a lot of home cooking, a lot of fried food and stuff. And it seems to be a very big cardiac county. I got other questions in here. So that's what you can expect from your ride-alongs is a mixed bag. It could really be anything, anytime, any place. And that's the fun thing about being a paramedic or EMT is that no day is the same. I probably have undiagnosed ADHD and I could never sit still. So for me, it was the perfect job to give me autonomy, but also to give me a change of pace every day. How does someone assist in giving drugs and meds? And are we getting paid for our third rides? Getting paid for your third rides is going to be a Jonathan question, but I can tell you that the state of Georgia has never, in my experience of teaching since 2012, allowed someone to be paid for a third ride. It's some type of ethical issue that they have. So I'd run that question by Jonathan, the training director. But in my experience, the state of Georgia will not allow it to be counted as a third ride if you're being paid. Also, to assist somebody with meds and drugs means that they've already been prescribed nitro. Like you go to a chest pain, like you're having chest pain, sir? Yeah, buddy, I'm having chest pain. You got any nitro pills that they've been prescribed? Yeah, I got some right here. Well, let me help you take them. You pretty much just take their pills and give it to them. And at the EMTB level, that's kind of where you're kind of put in a box at. That's why a lot of the students like to go to the A class because they can actually give drugs based off protocols. Now, again, to give a drug, you must have training, authorization, and licensure. And if you have training or authorization, then you can get away with a lot. You can bend the protocols just a little bit. So even at the paramedic level, like I can only by protocol give like 100 mics of fentanyl for pain relief. But if I got a bad sick patient that's having a lot of pain, I can call them and be like, hey man, this guy's still hurting, bro. He's burnt from nipples to navel. You know what I'm saying? He's got a bad burn. I want to give him some more pain meds. And I'll just get a doctor to give me permission to do it. That's called passing the buck. You move that down the road a little bit, and because he gets paid the big bucks. Do you give nitro with every chest pain if they don't have contraindications? I would say no. No, there are times I withheld nitro based on the patient's blood pressure, based on if they took erectile dysfunction medications, based on if they were having an inferior myocardial infarction. This is why I'm telling you, as soon as you get there, you check to see if you do a 12 lead and have your medic read it and see if they're having an inferior MI. That's another contraindication to giving nitro is that they're having an inferior MI because they need a full tank to feed the heart. If you were ever inclined to give nitro to an inferior MI, you would probably have to give a fluid bolus first to get the blood pressure up high enough to do it. Let's see, don't lie for Forsyth as old people being old. There is a lot of old people up there. That's definitely true. How to know what station we're to do third rides at? That is picked by you and Frankie Phillips, who is the, I guess you'd call him the clinical coordinator. Frankie's good friends with him up there in Forsyth, and he knows the stations very well. I have not worked up there in years. When we first took over the Forsyth 911 and I was on the command staff, we had to fill in quite a lot. And, I just haven't been there in years. I think a lot of things have probably changed, but Frankie can help you with that. I'm sure you can get his email or contact from one of the other students in the chat room here. All right, what else you got? Again, you don't have me face-to-face often. This is your opportunity. If you're in the B class, I've already kind of gave you an example of what you'll be facing for your mod exam coming up. It'll be chapters 1 through 16, now to include chapter 17. I'll assign that work this week, but cardiology is what we're covering tonight. I'll probably be light on cardiology this week at least, but at least chapters 1 through 16 and the terrorism chapter, because y'all hit that as well. So you got a lot of material that's going to be on this next one. From the email I got, the med number we're going to be is at the fire station we're going to. That's probably true. That's probably true. Yeah. Yeah. So other questions you got? So like med 5 is station 5? I guess so. I ain't been up there in years, I can't know everything. I used to do the third rides, assign the third rides myself, but it's just too much to keep up with. There's like 40 of y'all all together. Oh my God, there's a grammar Nazi in the room. Shut up, Christina Shane. Nobody cares. What a loser. It's there. No, it's there. Can't help it. You can help it. All right, other questions. Come on, hit me while you got me. I will be live and in person this week with you. I will be at Roswell location Monday and Wednesday. So I think there's a mod exam this week for, I don't know, the B or the A class. I can't keep up with it until I look at my calendar, but I'll have it ready for you. Make sure you're studying and being ready for that. And then we're going to do deliberate practice. We're going to go back to the arena. We're going to work hard. The teacher in her is exposed. That might be true. And
Josh,
what?
we only had a lab for chapter 8.
Chapter 8 is just lifting and moving.
I know, but we only had a lab for that.
You're supposed to have a full-blown